Welcome back from the commercial break. This is Health Pot. Remember, this program is brought to you by Makerere University School of Public Health. And today we are with Fatna Garenda, our sign language specialist, and Dr. Sam Ononge, who is actually taking us through today's topic, and of course Edrine Osteen Mukalazi is my name. Doctor, before the commercial break, you were still telling us about the causes of the uterus failure to contract.
Yes.
And you had told us that there are some drugs. You're actually telling us about the drugs.
There's some, yes, thank you, Mukalazi. And indeed, there are some drugs we use in the hospital, sometimes to manage certain conditions, like the ones we use in theater, or like the ones we use for managing high blood pressure. They can also make the uterus basically fail to contract. Big babies occupy a big space, can also make the uterus basically to fail to contract. But there are also ladies who, at the same time, they're pregnant, but they have some swellings within the uterus. Medically, we call them uterine fibroids. Now, you find that they're a bit harder in one area and harder. So when the uterus is trying to contract, there is a bit of disturbance that it doesn't contract effectively. Those are the basic known factors which make the uterus fail to contract. And you find that these powers which I was telling you before leave the blood vessels so open that blood just flows through. And you find somebody, if you have ever slaughtered a chicken, the blood is just Or for people who have managed to slaughter a goat, that's how the blood is basically pouring. But there are also some people where you find it continues pouring slowly, but for a long time. The uterus contracts and relaxes. Uterus contracts and relaxes. In addition to that, we know that women who deliver without help sometimes do not get the drugs which help the uterus to contract.
Doctor, what do you mean by women who deliver without help?
Without help. They're either delivering on the way, they're delivering at home, knowing that in the hospital we give a drug which helps the uterus basically to do what? To contract. So in those circumstances, you find that she doesn't have access to those drugs, and she's prone to basically having excessive bleeding because this uterus has failed to contract. So failure of the uterus to contract is a major leading cause of excessive bleeding. In about 7 to 8 of them is as a result of failure to contract.
So, Doctor, you also talked about the tears.
Yes.
What causes these tears?
The tears, from where the baby is located is like an avocado. So the baby can be pushed through what we call the cervix, that is the mouth, or the entrance into the womb, and into the vagina and outside. So the tear can start as high as the uterus itself getting a cut. And that releases a lot of blood. But also the cervix is also a major area, as that door which lets the baby out can also do what? Can also tear. This usually happens if you push the baby before the uterus the cervix has completely opened. Because that cervix is supposed to open to what we call fully dilated to allow the baby to pass smoothly. But some people start pushing. The moment they feel the urge, they are pushing. They tell them, wait, I'm feeling the urge to do what? To push the baby. And if you push the baby, you can easily get a cut along the cervix. And then you get a cut along the vagina. There are also bad ones, and then a cut even as it comes out. There are sometimes where you find that who have assisted in delivering this baby, especially where the woman has tried to push, and the baby is not coming out, and we bring some assistance. Either we apply something to pull the baby slowly. Sometimes in that process, the woman can also experience a bit of trauma. And then, if obvious that your baby is big, and it stretches the birth canal to the extent that some areas it causes those cuts along the cervix. And in such a situation, you discover that the other time the uterus was big, but this time the uterus has hardened, but the bleeding continues to come. You suspect that they have got a cut. Naturally, we sometimes help. If, for example, the baby is just down here, we help by making a small cut. But that cut also can be extended by the baby as it's coming out. And it can also, the woman can experience excessive bleeding. So these are some of the tears which can occur along the way. Now, if that happens home, is a problem. If it happens in the hospital, then people are able to identify it, and then they're able to do what? To basically repair it. So
this actually is to emphasize that women should only give birth from health facilities so that you can actually get full health, not partial health, or no one else can assist you besides or except the health workers. And then, doctor, you also talked about the retained tissues.
Retained tissues,
yeah.
Yes.
What causes these retained tissues?
Yes. Now, the retained tissues also is a problem, not as big as failure to contract, but it happens. You find that sometimes the baby comes out and the whole placenta, the sac which was contained, stays inside. And when it is staying inside there, it doesn't allow the uterus to do what? To squeeze itself to stop this bleeding which is coming from those porous areas. It can happen. Naturally, that there's no risk factor, but it can stay there. But there are some situations where you find a piece of it, the other major part comes out, but the rest of it stays what? It stays back inside. Oh, you find it's just a big clot has stayed there. It doesn't allow the uterus basically to do what? To contract. So, but we have also seen that women who are delivered by cesarean section in the previous delivery, the placenta tends to hold so tightly on the scar which was cut inside there. So it causes when you're trying, the Musa or the midwife is trying to deliver the placenta, it is stuck there. It is stuck. Because the area which was cut is a raw area to hold the placenta because it is not separating nicely. You know, the placenta separates like how you peel a mature onion, a mature orange. It peels nicely after delivery. However, if it is a dare in that area, you're peeling like how you peel a very young orange. It is so stuck onto the peel, and that's what happens when it is so adherent on the wall of the uterus. So it can basically retain the tissues in that area.
Okay.
Yes.
Okay. So, doctor, I've talked about, because our topic today is excessive bleeding, and you told us that there is a reason as to why this blood fails to clot. What causes this blood not to clot?
Yes.
Because we expect it to clot after some time.
Thank you, Edrine. There are some situations where you find that this blood has failed to clot. This usually happens, for example, these women who have raised blood pressure. Remember I told you about raised blood pressure causes women to die. So those women can also have their blood failing to clot because the factors which help the blood to clot have been consumed away. Similarly, women who have a dead baby inside, and that dead baby has stayed longer periods inside without knowing that the baby is already dead, that baby can consume the factors which can help the blood to clot. Then there are situations where you find that naturally you are born with that problem. Even during your periods, your blood is not clotting freely, it just flows. Even when you are cut, you're easily bruised. You can easily fail to have a blood clot. And there are also women where you find that they are already anemic. They have low blood levels. Their blood flows very, very easily through. As they deliver, the blood is not clotting, and you're wondering why. Now, the other factor is that all the other factors, if you bled a lot, either the uterus has failed to contract, or you had a tear, or you had a retained placenta, when you are in that state of shock, you have bled a lot. Also, your blood may fail to do clot. Now, initially, it was clotting. As time goes, as you continue losing blood, you are at a level where even the little which is now coming is no longer clotting. So it is like a complication of all the others when you have bled basically a lot. Then you find that you have more than one complication now. And that is usually a challenge for us health workers, because when you reach that level, things are not good. And you find us thinking, what do you do next? What do you do next? So failure to clot in somebody where the blood was clotting before is a scare for us health workers, because Everything you're putting inside is what? Is getting out. What you're putting inside is getting out. What you're putting inside is getting out. So it becomes basically a scare for the people managing. So the issue is, if you are able to arrest the other ones before you reach this level of failure of the blood clot, that is usually good.
Meaning this is now the climax of the problem.
It is. You are in deep down there, and getting out from there is usually a challenge. It's challenge.
But is there hope that a mother can survive?
Yes, there is hope. There is hope. Now, out of all the women who experience excessive bleeding, we have few who end up losing. In our setting, because of challenges which are there, you find that about 3 to 4 of them pass on. That's percent. That's a big number. Out of 100, 3 to 4% of them we lose them. However, this depends on what you have at your facility, how prepared you are, what things are available, is there blood for you to transfuse this lady. All those things are factors. Are there drugs for you to help this woman basically stop the bleeding? So there is hope. There is hope. So long as you are in good setting and you're in good hands, that is very important.
So, doctor, as we emphasize women to go for antenatal, can some of these issues, especially the uterus failing to contract and all that, can they be anticipated before they happen? Or it is very hard to tell that your uterus may fail to contract and you might get a tear and all that?
Okay. Thank you, Edrine. Now, it is true, I listed above that if you have twin pregnancy, if you have a big uterus with too much water, if your baby is big, those are the ones we say these are basically risks. However, there are people who do not have any of that, and they end up having the uterus fail to contract. You saw this woman during antenatal, time of delivery, she delivered well, and middle of delivery like this, the uterus has failed to contract. So for us, we say every pregnant woman is at risk of what? Excessive bleeding. Even the one without a obvious risk that he has a big baby, has a raised blood pressure, it's at a risk. So the issue now is for us to prepare for every woman. So a bottom line for any woman says, for me I don't have twins. No. I don't have swellings in the uterus. For me I will not bleed alone. No. So long as you are carrying a pregnancy, you have a risk of what? Excessive bleeding. So you need to prepare for it. Prepare for it, and the only way you can prepare for it is from what? Antenatal. I told you that if you're anemic, you're at high risk. So in antenatal, you should have corrected the level of what? The blood level, to have it corrected to adequate level. During antenatal, you need to have your blood checked, so that we know what level is it. For a pregnant woman, we say your level should be above 11. The doctors or the midwives know what 11 is. 11 grams per deciliter. That is, you're not having low blood level. So above 11, that is good. But if you can even have 13, that is very good, because for a 13-gram level of blood in this lady compared to 7 grams, the 13-gram can bleed 2 tampecos and she can still be walking. A 7-gram can bleed half a tampeco and she can do what? She will just still stand for you. So that is very, very important. And I would encourage all pregnant women and men also, if you are attending for antenatal, emphasize and ask them, "Sao, you have a right. Ask them, "Sao, can my wife's blood be checked, and we know what's the level now, so that you know how to correct it, how to basically correct it."
Thank you so much, Dr. Sam. We are indeed grateful for today's session. Dr. Sam has been taking us through excessive bleeding, but of course, I want to assure you that there is a lot that we have not talked about, and we are going to host Dr. Sam next week, and he will actually tell us the other content that he has not shared with us today. Of course, I'm Edrine Osteen Mukalazi. I worked with Fatna, Garenda, the sign language specialist, together with Dr. Sam. Remember, this program is brought to you by Makerere School of Public Health, together with Family TV. Enjoy your weekend responsibly and have a good night. Until we meet again next week.